This is
Just
about
change flow
selection
one
of
for
open
wiring.
revascularization techniques. And as we have defined, inflow involves the infrarenal aorta, the iliacs, and the common femoral artery. We treat that as an inflow vessel, and everything infrainguinal will be below that, of course. So inflow procedures available to us includes EVT, which we've seen plenty so far, aortobifemoral reconstructions, thoracofemoral reconstructions, aortoiliac endarterectomy, and then extraanatomical reconstructions, including Ax-Bifem, as well as Fem-Fem bypasses. The topic today will be comparing these two or selecting which procedure would do what. Now, the elephant in the room, of course, is what exactly constitutes a no-option EVT in aortoiliac occlusive disease. And I think, realistically speaking, probably is going to be very little patients that will qualify for that. But again, every patient is an endovascular candidate. I think there needs to be a little bit of a thinking in terms of when you have common femoral involvement, particularly occlusions in the setting of aortoiliac occlusive disease. Probably not a good idea to tackle that endoluminally. Hybrid, probably a better choice. Highly calcified aorta and high bleeding risk. I think that's definitely something that we should think about. Advanced chronic kidney disease in patients who do not have any ability to tolerate procedures that are severely symptomatic. It's another stopgap there. Synchronous aneurysmal disease is something that probably will increase even more the risk of bleeding, as well as they play negatively in terms of EVAR performance. So maybe an open approach for these patients may be something that needs to be considered. So more than one way to skin the cat, of course, but at the end of the day, if you believe in your hands the patient is not a candidate to do an endovascular intervention, probably referral should be considered. Now, how do we, once we take that referral, we go through indications, variables, and arterial anatomy stratification, the guidelines, and the skill set that we all have. It's kind of a flight checklist. So in terms of indications, obviously the sibling claudication despite medical therapy or critical limb ischemia, either presented by tissue loss or ischemic rest pain, are the typical indicators. And of course, we're talking about the symptomatic post-EVT failure, which I mentioned this morning in the talk. In terms of the individual characteristics, we go through the comorbidities, ADLs, functional ability of the patient, which allows us to calculate a risk, and that plays a role into the equation. In terms of the arterial anatomy, we talk about performing preoperative CT scans for suprainguinal disease, degree of technical complexity, procedure long-term patency performance, less vessel characteristics, pathology. Where are we going to put the clamp proximally? It's going to be suprarenal, infrarenal. That's going to change the morbidity of the procedure, redo procedures, priority interventions. All those things we can gather from. We have seen this a million times already. And again, what we're looking is the red flags or the green go lights from the imaging in terms of proceed or not proceed or be worried. We know that the SVS supports the notion of a first line treatment with endoluminal approach to the aortoiliac occlusive segment. But again, we are reminded that when it's common femoral artery, when there's young patients, when there's aneurysmal disease, all those should be things that we need to think over. In terms of the CLI patients, definitely the good practice statement is if you have inflow disease, you should correct it by any means necessary when you're approaching this. That's the only good practice statement in terms of aortoiliac occlusive disease. So in terms of operation technical skills, I think, if you're this guy, you probably can do whatever you want. But if you're this guy, maybe you want to take your time. The second guy is my son in the Malaga Academy right now in Spain, trying to make himself, he's a 17-year-old and decided to leave the States and pursue some soccer future. We'll see how he goes. So in terms of open revascularization options, the ones that I was asked to compare, the more likely prevalent ones, it's aortobifemoral bypass graft versus an axillofemoral bypass graft. And you can see one is a cavitary operation with all the systemic complications associated with that, complex anatomy. I did about 3 aortas, open aortas, a week during fellowship. And as an attending, it took me probably 2 years to feel confident about doing them, suprarenal clamping, etc. I think the current fellow is doing 5 aortas in a year. So definitely learning curve is going to be a significant deal. Axillo bifemoral reconstruction is pretty easy, non-cavitary operations. Don't think it's going to be an issue. So in terms of indications, again, there's no difference between the two procedures in terms of selection. Both procedures should be applied for the typical vascular indications. In terms of the risk stratification, I think We take all these variables that I show you here, and it comes with an average risk or a high risk based on the percentage of morbidity, mortality, as well as the estimated survival at 2 years. And we adjudicate patients to the aortobifemoral bypass when they have an average risk, and we adjudicate axillofemoral bypass in patients who have a high calculated risk. In terms of the arterial anatomy, again, where we put the clamp, where the aneurysmal disease is present or not, where there's renal revascularization needed, versus when you have an axillofemoral bypass, which is a hostile aorta or adequate, and we have to have adequate iliac inflow. And you've seen this CAT scan with a coral reef aorta in your practices, I'm sure. And this is, like they were saying in the previous panel, unclampable aortas, and it's really not fun. I've been in a couple of these, and I tell you, it's not fun when you clamp and you crack the aorta, particularly in open rupture aneurysms. They're heavily calcified. It's really, really a difficult thing. There's really no current guidelines in terms of differentiating when to do what. It's just, I think, a little bit of surgical common sense. And the skill set, I think, is something that's going to affect the future. I think we're still around, those of us who train heavily in aortic volume, but I think in the future this is going to play a major role, and there's not going to be current issues in axillofemoral bypass. So as you can see, probably, hopefully by now, we all agree with me that aortobifemoral bypass or axillobifemoral bypass are really apples and oranges, and they should be used selectively when indicated. This is a reminder that there are other types of modalities that we use sometimes, thoracofemorals, as well as direct endarterectomies of the aorta. So, in summary, an end-of-first approach is supported by guidelines for the aortoiliac occlusive disease. Open surgical evaluation is the basic tenet. Due to low volume during vascular surgery fellowship and progress of endovascular technology, I think the future of aortobifemoral is actually uncertain, and axillofemoral bypass will continue to play a role. Last thought, nobody argues with success, and when all these interventions that are complex go well, everything is great. But if you have a complication, might as well have one in somebody who was turned down by a vascular surgeon. Thank you very much.